You will be given, I think the recording has started now. Okay, so uh, just a quick recap. My name is Dr. Nazish Mughal. I am the mentor at Med Exam Expert for the MRCPCH course, Foundation of Practice. And before we start with the actual webinar topic, the acyanotic and cyanotic heart diseases, just uh, some pieces of information for our participants is that the med exam expert team, it is launching an important exam oriented question workshop which is of 1 month duration starting from 20th of January 2026. And the constituents or the components of the workshop are they can you have you will be having access to the live sessions of workshop. The topic 5 session recordings will be there. You can have access to the PDF of the live sessions. You will have access to the mock exams of last 6 years, six papers, last 5 year recalls, and a question bank comprising of 3000 foundation of practice questions, and a question bank for the theory and science exam, which will be comprising of 2000 questions. And all the important files and all the important and relevant notes will be there. And there will be, of course, group discussions, study groups on the Telegram as well as WhatsApp. Again, you can see the website and the contact number. You can contact the team and they will guide you further. Um, and something else which is very exciting for all the participants, it is that the Med Exam Expert team is offering a mega sale for the month of December, and you can have a 50% of discount on all the courses available. For further information, you can contact on the number given on your screens. Excuse me. So, as I said, that the cardiology is a very vast topic, um, and I personally find that 1 hours or 2 hour or 3 hour is quite less to understand the entire concept and to have a good grasp of all the important diseases. But we will discuss very briefly about the acyanotic diseases, the important ones, and the cyanotic heart diseases, which are the important ones. Um, so, uh, before we start, this is just a normal four-chambered heart, a schematic diagram to help you understand. You can see the four chambers of the heart, which is the right atrium, the right ventricle, the left atrium, and the left ventricle. The right atrium and the right ventricle, the right side of the heart here is blue in color, which shows that the presence of the deoxygenated blood in the right circulation. And the left side of the heart, the left atrium and the left ventricle, you can see red in color because it is oxygen rich and oxygenated blood. Okay, so from the right atrium, the blood is received from all the parts of the body through the superior vena cava and inferior vena cava. From the right atrium, the blood flows through the tricuspid valve into the right ventricle. From the right ventricle, the blood flows through the pulmonary trunk into the lungs for oxygenation. From the lungs, the oxygenated blood, the good blood, is carried by the pulmonary veins to the left atrium, and this left atrium uh, pushes the blood through the mitral valve into the left ventricle, and from the left ventricle through the aorta, the oxygenated blood, it is supplied through the body, and again through the body the vena cava takes the deoxygenated blood, and this is the whole systemic and pulmonary circulation. So if you understand this basic diagram, you'll be able to understand the congenital heart defects. So, first of all, we will talk about the acyanotic heart conditions, and the acyanotic heart conditions are broadly categorized into two main types: those which are associated with the increased pulmonary blood flow, and those which are associated with obstruction to the outflow of the blood. Those associated with the increased pulmonary blood flow, they include atrial septal defect, ventricular septal defect, patent ductus arteriosus, and AV malformation. From these four, ASD, VSD, and PDA are important, so we will discuss the important features of these three. Obstruction to the blood flow. Uh, Outflow of the blood includes aortic stenosis, pulmonary stenosis, and coarctation of aorta. So let us start with the atrial septal defect first. So atrial septal defect, before I go through the contents of the slide, let me just explain you the pathophysiology, what actually happens in the atrial septal defect. So in the atrial septal defect, what happens is that there is some defect in the septum which is dividing the right atrium and the left atrium. So after the birth, the systemic circulation resistance increases, and the resistance of the pulmonary vasculature, it decreases. So the blood tends to flow from the systemic circulation to the pulmonary circulation, that is from the left side to the right side in case of any defect. So in ASD, what happens after the birth? There is some hole or defect in the atrial septum. So there is room for the blood to flow from the left atrium to the right atrium. So the blood that is received in the right atrium from the pulmonary veins, after oxygenation in the lungs, this oxygenated blood, it gets mixed up in the right atrium with the deoxygenated blood. So this right atrium, in addition to receiving the deoxygenated blood from the superior vena cava and the inferior vena cava, it also receiving an additional blood from the left atrium, and thus there is overload of the blood in the right atrium, and this overloaded uh, right atrium then moves all of its blood through the tricuspid valve into the right ventricle, and this right ventricle pushes the blood into the pulmonary trunk. So you see that on the right side of the heart, there is increased load of the blood. Whereas on the left side of the heart, since all of the blood it has traveled from the left atrium to the right atrium, so the load of the blood on the left side of the heart is less. So the more blood is flowing through the lungs, so there will be increased vascularity of the lungs, and the lung fields on the chest x-ray, you can see that the lung fields are plethoric. So if their blood flow to the lung fields is increased, the lung fields are known as plethoric. If the blood flow to the lung fields is decreased, there will be some conditions in which the blood flow is decreased. For instance, TOF, which is a cyanotic heart condition, then it means that the lung fields are oligemic. So this is the basic pathophysiology of the ASD. So ASDs, they are constitute about 5 to 10% of the congenital heart diseases. They are less common than VSD, more common in females. The pattern of inheritance is sporadic, but Holt-Oram syndrome, it is an autosomal dominant syndrome, and it is associated with ASD. There are different types of ASDs. One is ostium secundum, ostium primum, sinus venosus ASD, and coronary sinus ASD. We will discuss the ostium secundum here. So ostium secundum is the most common ASD, and is the defect in the central portion of the atrial septum in the position of the foramen ovale. So you remember from the fetal circulation, there is a foramen ovale through which the blood was flowing from the right side to the left side and was bypassing the lungs. So if the foramen at the position of the foramen ovale in the central position of the atrial septum, if there is a defect or hole present, then this will constitute ostium secundum. So they can be single defects or multiple defects. Mostly they are asymptomatic, but if the size of the defect is more than 2 centimeters, it will produce signs and symptoms. More common in females, and female to male ratio is 3:1. Associated with the partial anomalous pulmonary venous return. ASD is not associated with the risk of congestive heart failure, and there is no risk of infective endocarditis. So, infective endocarditis prophylaxis is not indicated. So, the pathophysiology, there is left to right shunt, and again, the degree of the left to right shunt depends on three things. First, the size of the defect. If the size of the defect is less, there will be less blood which will be shunted from the left side of the heart to the right side of the heart. The compliance of the ventricle and the resistance in the pulmonary and systemic circulation. So, as the child is born, a newborn has a thick muscular wall of the ventricle, so it is less compliant and does not welcome more amount of the blood from the left side of the heart to the right side of the heart. So again, the resistance in the pulmonary and the systemic circulation. So QPQS ratio, it is actually the ratio between blood flow in the pulmonary circulation and the systemic circulation. So the QPQS ratio in the ASD ranges from 2 is to 1 to 4 is to 1. If the QPQS ratio is more than 1, this shows that there is left to right shunt. If it is less than 1, this shows that this is right to left shunt. And the paucity of symptoms in the infants is due to less compliant heart chambers. As the infant grows, the muscular wall of the ventricles becomes less thin and more compliant and is happy to accommodate more amount of the blood. So the degree of the shunt increases. And as the right atrium, the right ventricle, the pulmonary artery is receiving more blood from the left side of the heart through the ASD. And again, all of this blood is going to the lungs, and from the lungs, there is a increased volume of the blood which is received by the left atrium. So the enlargement of the right atrium, right ventricle, pulmonary artery, and the left atrium can be seen. So you can see this is again the pathophysiology that I have always already explained. I hope it is clear by now. And let us see the clinical manifestations of the ASD. So ASD is mostly asymptomatic. There can be recurrent chest infections. Again, if the degree of the shunt is large, and this will lead to failure to thrive. There is platypnea. Platypnea means that there is dyspnea on standing, and which is relieved by being on supine position. There is orthodeoxia, which is the desaturation on standing and which is also relieved on lying supine. There can be mild precordial bulge due to right ventricular enlargement. And the most characteristic finding of the ASD is fixed wide splitting of the second heart sound. The characteristic murmur of the ASD is systolic ejection murmur at the left upper sternal border. And because of the increased blood flow across the tricuspid valve, you can also hear a short rumbling mid-diastolic murmur at the left lower uh, sternal border. And this is to be heard with a bell because it is very soft. The QPQS ratio is 2 is to 1, and arrhythmias can be seen in around fourth decade of life. How is ASD diagnosed? So, in order to diagnose any congenital heart disease or any heart defect, chest X-ray, ECG, echocardiography, and cardiac catheterization is done. Now, we will see the characteristic features in each of these diagnostic modality. So, on the chest X-ray, you can see the enlargement of the right atrium, right ventricle, pulmonary artery. There will be cardiomegaly. There will be plethoric lung fields. You can see the prominent pulmonary artery segment, and you can see the right ventricle protrudes out. On the ECG, you can see the right axis deviation and partial right bundle branch block, and you can also see right ventricular conduction delays. On echocardiography, you can see the right ventricular overload, increased right ventricular end diastolic dimensions, and flattening and the abnormal motion of the ventricular septum. On cardiac catheterization, it is only done when there is suspicion of pulmonary vascular disease in order to measure the pressure in the pulmonary vasculature, resistance, and the shunt ratios. The treatment of the ASD is as follows now. So all symptomatic patients, they undergo transcatheter surgical device closure if the QPQS ratio is at least 2 is to 1 or there is right ventricular hypertrophy. Surgical mortality, it is greater in adulthood, and elective closure after 1 year of age or before the age of 3 to 5 years, which is um, the preschool age, it is done to prevent arrhythmias and right heart failure. The procedure of choice in case of the ASD is percutaneous catheter device closure using atrial septal occlusion device implanted transvenously. And if the defect is very minimum, there is not right ventricular hypertrophy, then the closure is not done. So this marks the end of the ASD. I hope it is clear. Let us move forward to the ventricular septal defects. So ventricular septal defect, what is a VSD? VSD is a defect in the septum that divides the right and the left ventricles. It is most common congenital heart disease. It can be isolated or it can be a part of a complex malformation. It can be associated with AST, PDA, intracardiac obstructions like subpulmonic, subaortic, and mitral stenosis. Can be associated with the AV valves. There is risk of congestive heart failure and there is risk of infective endocarditis. So prophylaxis for infective endocarditis is required. The classification of the VSTs, it is very tricky, and it is classified on a variety of parameters such as anatomical classifications on the basis of size, on the basis of pressure and ventriculography. But for the purpose of simplicity and the scope of this exam, we will only discuss the classification based on the size and the classification based on the pressure. So, the classification based on the size says that there are three types of VSTs: the small VST, the moderate sized VST, and the large sized VST. So, in the small VST, the size is less than one third of the size of the aortic root. The moderate VST, the size is less than half of the size of the aortic root, and the large VST, the size is more than equal to the size of the aortic root. Excuse me. So on the basis of the pressure, there are three types of the VST: the restrictive VST, the moderately restrictive VST, and the non-restrictive VST. So in the restrictive VST, the QPQS ratio is less than equal to 1.4 is to 1. The moderately restrictive VST, the QPQS ratio ranges from 1.4 to 2.2 is to 1. And in the non-restrictive VST, the QPQS ratio is more than 2.2 is to 1. Okay, so you can see a flow chart in the blue. This shows the pathophysiology of an important phenomenon known as the Eiser-Menger phenomenon or the Eiser-Menger syndrome. So what happens in the VST? So in the VST, you know that there is a defect in the interventricular septum that divides the right and the left ventricle. So let me uh, take you back to this diagram. So there is a defect here in between the left ventricle and in the right ventricle. So what happens after the birth? The blood tends to flow from the left side to the right side. So VST is again an example of the left to right shunt like AST. So the blood is flowing from the left ventricle to the right ventricle and from the right ventricle to the pulmonary artery to the lungs. So the blood continues to flow. What happens that in case of large VSDs or in long-standing cases, as a result of continuous left to right shunting, there comes a point when the pulmonary circulation cannot accept more amount of the blood from the left side. So what happens? The resistance in the pulmonary vasculature increases. When the resistance in the pulmonary vasculature increases and the blood in the pulmonary circulation and the blood is no more accepted in the pulmonary circulation, so what happens? There is reversal of shunt. So instead of being from left to right, the shunt becomes the right to left shunt, and hence there is mixing of deoxygenated blood into the oxygenated blood, which is then supplied to the body. So there is cyanosis. And this reversal of the shunt is known as the Eiser-Menger syndrome. So this flowchart again shows the pathophysiology. So in the presence of the congenital heart defect, which has left to right shunt, increased amount of the blood volume on the right side, this leads to endothelial dysfunction and pulmonary vascular remodeling. This results in irreversible changes in the pulmonary vascular resistance and leads to pulmonary hypertension. When there is pulmonary hypertension, the blood is no longer accepted in the pulmonary circulation from the systemic circulation. So there is reversal of the shunt. Instead of being left to right, the shunt becomes right to left, and hence there is Eiser-Menger syndrome, and there is marked cyanosis and there is clubbing as well. So I hope the pathophysiology is now clear. The clinical manifestations of the VSTs are as follows. In the small VST, they can be asymptomatic, normal growth and development is there. In the moderate to large size VSTs, what happens? There is repeated pulmonary infection because of the increased pulmonary blood flow. There is faltering growth. There is reduced exercise intolerance. There can be features of the congestive heart failure. And with the long-standing VSTs, there is pulmonary artery hypertension, cyanosis, and decreased level of activity. So, on examining a child with VSD, what you will find in case of small VSD, the examination is unremarkable. But if there are signs and symptoms, then you can find a systolic thrill at the left lower sternal border. There is precordial bulge. The P2 is normal with small shunts, however, it is enhanced with the large shunts. The second heart sound is loud, single in pulmonary arterial hypertension, or when the pulmonary vascular obstructive disease is there. And the characteristic murmur of VSD is a pansystolic murmur, also known as a holosystolic murmur at the left lower sternal border. And you'll also able to appreciate apical diastolic rumble. Okay, so there is an important concept here that I would like to emphasize on. The intensity of the murmur, it is inversely proportional to the size of the defect. So you see the murmur is the abnormal sound which is produced because of the turbulent blood flow. So if the size of the defect is less, the intensity of the murmur will be more because there will be more turbulence to the blood flow and more restriction. However, if the size of the defect is large, the intensity of the murmur will be decreased. And the apical diastolic rumble is because of the increased blood flow across the mitral valve. Then diagnosis, ECG, chest X-ray, echo, and cardiac catheterization is done. On the ECG, you can find uh, no findings at all in case of the small VST. In case of moderate sized VST, you can find the left ventricular hypertrophy. Uh, and occasionally left atrial hypertrophy. In case of large VSTs, you can find biventricular hypertrophy with or without left atrial hypertrophy. Chest X-ray will show cardiomegaly and plethoric lung fields. And echocardiography will show the exact location, the size of the defect, the number of defects, the shunt magnitude, pulmonary artery pressure, and other associated defects if present. Cardiac catheterization will show increase in the oxygen saturation in the right ventricle in the pulmonary artery, reflecting the left to right shunt. I hope that everything that is being discussed is clear to you. If you have any questions, we will be discussing them at the end of the session. So please note down all the questions you have. I will be more than happy to answer them at the end of the session. The management of the VST constitutes medical management and the surgical management. So, in the medical management, rest, oxygen supplementation, diuretics, ACE inhibitors, occasionally are given digoxin, vasodilators, infective endocarditis prophylaxis is indicated, and if there is pulmonary artery hypertension, exercise restriction is indicated in addition to the increased caloric input. Device closure and surgical treatment is indicated if QP and QS ratio is more than 2 is to 1, and if the ratio is less than 1.5 is to 1, no surgery is indicated. The timing of the surgery is important. Infants who have congestive heart failure or growth retardation and they are unresponsive to the medical treatment, the surgery should be done at any age, including the early infancy, to close the defect. In case of large VSD and those having increased pulmonary vascular resistance, the surgery is done as early as soon as possible between the ages of 3 to 6 months. Infants who are responding to the medical treatment, the surgery is done at the age of around 12 months to 18 months, and those who are asymptomatic, the closure is done between 2 to 4 years of life. So this marks the end of the VST. Let us now start with the third important acyanotic heart condition, which is the patent ductus arteriosus. So, in the fetal circulation, there is a connection known as the ductus arteriosus between the pulmonary trunk and the aorta. And after the birth, the ductus arteriosus it obliterates and it is closed so that there is no abnormal communication between the pulmonary and the systemic circulation. But sometimes what happens, it remains open and results in the clinical manifestations, which we will be discussing now. So, Patent ductus arteriosus, it is a communication between the pulmonary artery and the aorta just distal to the subclavian artery. More common in females, the ratio in female to male is 2 is to 1. The functional closure, it occurs soon after birth, but if there is failure to close between the 48 to 96 hours of life, it results in the left to right shunt. Uh, there is resultant overloading of the pulmonary circulation, increased blood flow, plethoric lung fields, repeated pulmonary infections, and unexplained respiratory worsening. So again, if you go back to this simplified diagram of the pulmonary and systemic circulation, if there is abnormal communication between the aorta and the pulmonary trunk, again there will be left to right shunt. More blood will be flowing from the left side of the heart to the right side of the heart, and hence there will be more blood flowing to the lungs, and more blood will be coming back to the left atrium. So there is overload on the right side of the heart. So the clinical features of the PDA are increased oxygen requirement, difficult to wean a baby from the oxygen, congestive heart failure, widened pulse pressure, bounding pulses, tachycardia, tachypnea, metabolic acidosis, retention of carbon dioxide. A very high yield characteristic feature of the PDA is continuous machinery murmur at the left second intercostal space and below the left clavicle. There is acute renal compromise, necrotizing enterocolitis, left atrial and left ventricular enlargement, intraventricular hemorrhage, and increased pulmonary blood flow. For the purpose of diagnosis, a chest X-ray, ECG, and echo are done. The chest X-ray will show the enlargement of the left atrium and the left ventricle, which is evident from the pathophysiology, plethoric lung fields, prominent pulmonary artery causing middle segment of the left silhouette of heart prominent, and cardiomegaly. On ECG, you will see the left ventricular hypertrophy or biventricular hypertrophy. And echocardiography will show the hemodynamics and their effect present. So for the PDA, prematurity is a risk factor. If a term baby is born with PDA, so the wall is deficient in the mucoid epithelial layer and the muscular media, hence it will not close spontaneously. However, in a preterm baby with PDA, there is a chance that it closes spontaneously. So the treatment involves the fluid restriction. About 60% of the maintenance fluid is given. Avoiding of hypoxia and acidosis. There is no role of digoxin. They are only given in VSD, and the prophylaxis for the infective endocarditis is indicated in case of PDA. So the medications which are preferred for the treatment or of the PDA are ibuprofen or indomethacin, and among these two, ibuprofen is more preferred. Why is it more preferred? Because it is associated with a lower incidence of oliguria, lower incidence of the renal adverse effects, and there is lower chance of developing the necrotizing enterocolitis. So if the baby is on full external fields, oral ibuprofen is indicated. Indomethacin, it is also a drug of choice for the PDA, but it is less preferred as compared to that of the ibuprofen because it is associated with the increased risk of the necrotizing enterocolitis, and it is given to the babies who are on IV fluids or who are receiving the total parenteral nutrition. The surgical management involves the closure with the coil occlusion device via cardiac catheter, and it is done ideally at the age of 1 year of life. Okay, so now that we have talked about the ductus arteriosus, let me discuss very briefly about the lesions which are duct dependent and those which are not duct dependent or duct independent lesion. This is also an important concept. So the ductus dependent lesions are further classified into two broad categories, which is the ductus dependent systemic circulation and ductus dependent pulmonary circulation. So in these conditions, the ductus arteriosus has to be kept open. If it is not kept open, this is life-threatening and detrimental. So in order for the baby to survive, the prostaglandin E1 infusion is given to keep the ductus arteriosus patent and to help the baby survive. So ductus dependent systemic circulation includes hypoplastic left heart syndrome, critical aortic stenosis, Shown complex variants. Uh, the shown complex means the left-sided obstructive lesions of the heart and coarctation of aorta and interrupted aortic arch. And the ductus-dependent pulmonary circulation lesions are TOF with pulmonary atresia, um, pulmonary atresia with intact interventricular septum, critical pulmonary stenosis, tricuspid atresia with pulmonary stenosis or pulmonary atresia, single ventricle with pulmonary stenosis or pulmonary atresia, Swear Epstein anomaly, uh, complete TGA with intact interventricular septum. And the ductus independent circulations, they are total anomalous pulmonary venous return, truncus arteriosus, and L kappa. So, in all of these conditions, in the ductus dependent systemic circulations, hypoplastic left heart syndrome is a condition in which the left side of the heart is not well developed. So, there will be no blood flowing to it, and hence, what will happen? The blood will not be available to be distributed to the body through the aorta. So, what happens? The ductus arteriosus has to be kept open by giving a transfusion or infusion of prostaglandin E1 so that the blood is able to flow. In case of critical aortic stenosis, again, the left ventricle is not able to send the blood from the left ventricle into the aorta because of the obstruction in the outflow tract. So again, the ductus arteriosus has to be kept open with the prostaglandin E1. If it will not be opened with the help of the prostaglandin E1 infusion, this is detrimental and the baby is going to collapse. Again, in coarctation of aorta, there is narrowing along the length of the aorta, so the blood is not going to flow and distribute evenly across the systemic circulation. So the ductus arteriosus has to be kept patent. In case of TOF with pulmonary atresia, so again there is obstruction to the outflow tract from the right ventricle, so the ductus has to be kept open. Similar is the case with the pulmonary stenosis, tricuspid atresia, and the single ventricle. So I hope the concept behind the ductus dependent and the ductus independent lesions is clear now. Let us move forward to the coarctation of aorta. So these are my own handwritten notes that I have included because I will be just discussing the important high yield points for each of the remaining diseases. And at the end of the session, you can go through the entire PDF, and this will give you again a better understanding. Okay. So coarctation of aorta means that there is, I think one of you has not uh, mute. Okay, I cannot see. I cannot see anyone whose mic is not mute. Okay. Okay. So coarctation of aorta means that there is narrowing or stenosis across the length of the aorta, and it can happen at any point from the transverse arch to the iliac bifurcation. It is more common in males, and the ratio in males to females is 2:1. It can be a feature of Turner syndrome, can be associated with bicuspid aortic valve, and if there is a complex of left-sided obstructive heart lesions, this is known as shown complex, and shown complex, it is also a ductus dependent systemic circulation lesion. So, in the first few days of life, the PDA may serve to widen the juxtaductal area of the aorta and provide temporary relief from the obstruction. And PDA can also mask the signs and symptoms of the coarctation of aorta. This is why we say that this is the duct dependent lesion. So, there is left to right shunting across the ductus, and this occurs in the acyanotic infants. And with more severe just juxtadustal coarctation of aorta or in the presence of transverse arch hypoplasia, right ventricle blood flow is ejected through the ductus arteriosus to supply the descending aorta. So the lower part of the body, it is again dependent on the right ventricular output. In this situation, what happens is that the femoral pulses are palpable. The difference in the BP may not be helpful in the diagnosis. However, the oxygen saturation would be different in all four limbs. So, in case of ductal right to left shunting, it is manifested as differential cyanosis, which means that the upper extremities which will be pink and the lower extremities will be blue. Such infants, they have severe pulmonary artery hypertension because of increased pulmonary vascular resistance. There are no signs and symptoms of congestive heart failure which are prominent. Coarctation of aorta, which was associated with arch hypoplasia, was once referred to as the infantile type because it was very severe, and it led to the recognition of coarctation of aorta in the early infancy. Hence, it was known as the infantile type. So, in case of the narrowing or stenosis at any point across the length from the transverse arch to the bifurcation of the ileum, the BP and the pulse pressure prior to or before the narrowing is high, and the BP and the pulse pressure below the narrowing, it is low. So if the coarctation of aorta, it is not corrected surgically in the early infancy, what happens? There is a development of the extensive collateral circulations, and these collateral circulation, it is directly derived from three of the main arteries, which are the subclavian arteries, the superior intercostal artery, and the internal memory artery. And the purpose of this collateral formation is to bypass the coarctation of aorta and restore the circulation. With the passage of time, these collateral vessels, they become increasingly enlarged and tortuous by early adulthood. The clinical manifestations of the coarctation of aorta, they include the coarctation of aorta. The adult type, it is recognized after the infancy, and it is usually not associated with any significant signs and symptoms. However, sometimes weakness or pain or claudication in the legs after the exercise is reported, and some are asymptomatic even in case of severe coarctation of aorta. So, older children, they are found to have high blood pressures on the routine examination. So, if you find a child who has high blood pressure, it is very important to rule out coarctation of aorta. The classical sign which is present in the coarctation of aorta is the difference in the pulsation and the blood pressure in the upper limbs as well as in the lower limbs. So the femoral, popliteal, posterior, tibial, dorsalis pedis arteries are either weak or absent. In contrast to the bounding pulses of the arms, carotid, radius, and femoral must be palpated simultaneously for the radiofemoral delay. If there is coarctation of aorta, the radiofemoral delay will be there. The radiofemoral delay occurs when the blood flow to the descending aorta depends on the collateral circulation. So, in case of coarctation of aorta, there is no precordial impulse. It is normal. The normal heart sounds are there. There is no change in the shape of the heart. Normally, what happens that the blood pressure in the lower limbs, it is 10 to 20 millimeters of mercury greater than the blood pressure in the upper limbs. And in case of coarctation of aorta, the upper limb and the lower limb pressure gradient, it is increased with the advancing age, and the blood pressure is also increased. In case of a bicuspid valve, a systolic ejection click or thrill in the suprasternal notch is appreciated. Uh, and the murmur in case of the coarctation of aorta, it is an extended murmur which can be appreciated at the left infrascapular area. In case of well-developed collateral circulation, asystolic or continuous murmurs, they can also be appreciated over the right and the left side of the heart, laterally as well as posteriorly. In case of severe coarctation of aorta, in which the lower part of the body, it is not receiving any of the blood circulation, there will be hyperperfusion and shock-like symptoms, acidosis, and congestive heart failure. The diagnosis of coarctation of aorta will again involve carrying out certain modalities such as imaging. On the chest X-ray, you can see the pulmonary congestion, inferior rib notching can be seen. Descending aorta has post-stenotic dilatation. ECG can either be normal or can have features of the left ventricular hypertrophy. And in case of severe coarctation of aorta, there can be biventricular hypertrophy or right ventricular hypertrophy. 2D echo will show the mitral and the aortic anomalies, and color Doppler can show the site of the obstruction, the pressure gradient at the area across the narrowing, and the cardiac catheterization will show the collateral blood circulation. The treatment of the coarctation of aorta, it involves the closure. Uh, as I said, that the closure of the ductus will result in life-threatening events. So in the neonates, what is done? The prostaglandin E1 infusion is given to keep the ductus patent. Otherwise, there will be hypoperfusion, acidosis, collapse, and there will be rapid worsening of the baby. Once the diagnosis is confirmed, patient is stabilized, the surgical repair is done. After the surgery, the rebound hypertension can be there in the immediate post-op period, and there can be striking increase in the amplitude of the pulsations in the lower limb, but it is transient and it will subside gradually. So now we know that coarctation of aorta is of two types, the adult type and the one which is very severe, which is manifested as hypoxia, acidosis, and collapse in the baby. And it requires the prostaglandin E1 infusion, and after that the definitive repair is done. And the adult type is all that we have discussed up till now. Okay, so this is the end of the coarctation of aorta, and we are left with just 15 to 20 minutes. So I will skip the aortic stenosis details and the details of other conditions, and we will discuss TOF, which is an important cyanotic heart condition, for because TOF is very important for the purpose of this MRCPCH exam. So for aortic stenosis, you must remember one thing, which is that the characteristic murmur. So in aortic stenosis, there will be ejection systolic murmur at the right upper sternal edge, and it will be radiating over the carotids or the neck. This is very high yield. So, in addition to this, I will just briefly go through the pathophysiology of the aortic stenosis. So, in aortic stenosis, what happens is that the door through which the blood has to flow from the left ventricle into the aorta, it is narrow. Either there can be less narrowing or more narrowing, that depends. But since there is stenosis, there is less room for the blood to flow from the left ventricle to the aorta. The left ventricle has to face the increased pressure to pump its blood. So there will be decreased cardiac output. There will be left ventricular hypertrophy because it has to pump more across high resistance. There will be increase in the back pressure in the left ventricle, in the left atria, and hence there will be back pressure in the lungs. So there will be pulmonary vascular congestion and pulmonary edema will be there. The signs and symptoms are that it can be asymptomatic, but in case of critical or severe, there can be signs and symptoms of hypoperfusion, respiratory distress because of pulmonary edema, exercise intolerance, chest pain, and syncope. And the characteristic murmur is ejection systolic murmur at the right upper sternal edge, which is radiating to the neck or the carotids. So this is just very briefly um, about aortic stenosis. So uh, I will discuss the pathophysiology of the pulmonary stenosis and the characteristic murmur, which is very important from the exam point of view. Uh, so the in pulmonary stenosis, what happens is that in the aortic stenosis, there was narrowing to the outflow of the blood from the left side of the heart, and in the pulmonary stenosis, the same thing is happening but on the right side. So the outflow tract from the right ventricle into the pulmonary tract, it is narrowed, so there is less room for the blood to travel from the right ventricle into the pulmonary artery because there is less space. So what happens is that there is narrowing at the entrance of pulmonary artery, there is increased resistance to the blood flow, the right ventricle has to exert more to pump the blood because of the narrowed passage, there is increased pressure in the right atria, Because of increased pressure in the ventricle, increased pressure in the atria, there is reopening of the foramen ovale. Because of reopening of the foramen ovale and increased pressure, the blood will be flowing from the right side to the left side. So whenever the blood flows from the right side to the left side, there is cyanosis. So there will be systemic cyanosis there. The characteristic murmur of the pulmonary stenosis is the ejection systolic murmur at the left upper sternal border, and the murmur of the ASD is also present at the left upper sternal border. But in order to differentiate these two, the pulmonary stenosis has severe systemic cyanosis, and the murmur is also radiating to the back, which is not happening in case of the ASD. So these are the high yield points for pulmonary stenosis. So, uh, brief discussion of the hypoplastic left heart syndrome. So hypoplastic left heart syndrome, it is also important duct dependent lesion. It is constitutes about 1% of congenital heart disease, and it means that there is underdevelopment of the left side of the heart. So what is the pathophysiology? The pathophysiology is that there is hypoplasia of the left ventricle, there is aortic atresia, and there can be small mitral valve. So the blood from the left atrium flows through the patent foramen ovale to the right atrium, from the right atrium to right ventricle pulmonary artery and to the lungs, and then through the PDA to the descending aorta, and then supplies the systemic circulation. So the clinical features are that the neonate is critically ill in the first few days of life. There can be signs and symptoms of impending shock, tachycardia, hypoperfusion, pulmonary crackles can be there, and weak peripheral pulses. And the S2 is loud and single. So on the diagnosis can be made antenatally or postnatally. Postnatally, ECG is done, which will show the right ventricular hypertrophy. The chest X-ray will show the pulmonary venous congestion, pulmonary edema, and the treatment involves the immediate stabilization and resuscitation, treating the acidosis, giving prostaglandin E1 to maintain the ductal patency, and surgical correction is done with in steps. The procedures are Norwood procedure. Um, and then a final repair, and the last resort is transplantation. So this is the end of the acyanotic heart diseases. Then let us discuss cyanotic heart diseases. We will not go into the detail of each of the cyanotic heart diseases. I will only be discussing the tetralogy of Fallot, which is very, very high yield. So in the cyanotic heart diseases, again, they are broadly classified into increased pulmonary blood flow and those associated with the decreased pulmonary blood flow. So the increased pulmonary blood flow, where there is plethoric lung fields, there is transposition of the great arteries, total anomalous pulmonary venous return, and truncus arteriosus. And those associated with a decreased pulmonary blood flow is TOF, tricuspid atresia, double outlet right ventricle. So in these all of these conditions, there will be oligemic lung fields. Okay. So now the tetralogy of Fallot. So tetralogy of Fallot is a very important cyanotic heart condition. It has four important components, which are the pulmonary stenosis or right ventricular outflow tract obstruction. There is right ventricular hypertrophy. There is VSD, and there is overriding of aorta. So in the isolated VSD, there was left to right shunt, but it is very important to keep in mind that in case of the TOF, through this VSD, there is left to right shunting going on, because there is pulmonary stenosis, there is again resistance to the blood flow from the right ventricle to the pulmonary artery, and there is right ventricular hypertrophy. So because of the stenosis and the right ventricular hypertrophy and increased pressure on the right side, there is right to left shunting and not left to right shunting, which is seen in the isolated VSD. The degree of the pulmonary outflow obstruction, it is directly proportional to the cyanosis which is present in the patient. And there is also an extreme form of the TOF, which is associated with the complete right outflow tract obstruction. That is, there is TOF and there is complete pulmonary atresia. In case of Mild to moderate right ventricular outflow tract obstruction, there is a balance shunt, and there is pink TOF. In case of severe right outflow tract obstruction, cyanosis is present from birth, and it will worsen whenever the ductus is closed. So this is also a duct dependent lesion. The clinical manifestations of the TOF are as follows. In case of mild right outflow tract obstruction, the infants, they initially present with the heart failure because of VSD. Um, and sometimes the infants are normal at birth, and the signs and symptoms, they appear later in infancy. In case of severe right outflow tract obstruction, there is severe neonatal cyanosis, and it will be present at birth, because the degree of cyanosis, it is directly proportional to the severity of the right outflow tract obstruction. In older children, the color is dark blue, gray sclera can be seen, and engorged blood vessels are seen, and there is marked clubbing of the hands and feet, because the degree and the duration of cyanosis, it is also directly proportional to the degree of clubbing. There can be dyspnea on exertion. Uh, the child may stop, sit for a while, and may lie down, characteristically squatting position, and able to resume the physical activity after a few minutes of squatting. So, what happens in case of squatting? Squatting compresses the femoral vessels. So, when it compresses the femoral vessels, there is increase in the resistance in the systemic circulation. So, when there is increase in the resistance in the systemic circulation, the cyanosis tends to get better a little. Then TOF is characterized by TET spells, also known as the hypercyanotic spells. So, what are TET spells? TET spells are paroxysmal hypercyanotic spells. They are very short lived, and they are a problem during the first 2 years of life. What happens in that the infant becomes hyperapneic, restless, cyanosis increases, can gasping can occur, and there can be syncope. They are more common in the early hours of morning, after waking up, during crying, after feeds, or after defecation. Temporary disappearance of murmur occurs because the blood flow through the right ventricle decreases because of the increase in the intensity of the stenosis. After the attack, what happens? There is generalized weakness. The baby may go to sleep. There are severe spells they are associated with a loss of consciousness, seizures, and hemiparesis. The TED spells, these are most common between the ages of 2 to 4 months of life. And in case of very severe hypercyanotic spells, there can be limpness, paresis, cerebrovascular accidents, seizures, or even death can occur. Infants who are mildly cyanotic at rest are more prone to the development of hypoxic spells, because they have not acquired the homeostatic mechanism to tolerate rapid lowering of the arterial partial pressure of the oxygen. And polycythemia, it is protective in TOF, so the target HB is kept above 10. What is the mechanism of the hypoxic spells? So, the hypoxic spells, they are caused by the unusual hyperactivity of the muscular fibers in the right ventricular outflow tract, and this causes the infundibular stenosis. When there is infundibular stenosis, there is increase in the pulmonary vascular resistance, there is increase in the right to left shunt, and there is increased in cyanosis, and hence the TED spells. So, in order to treat the TED spells alone, oxygen is not important. So, systemic vascular resistance has to be increased. And this systemic vascular resistance causes the reversal of the shunt, and hence there is reduced cyanosis, and there is some alleviation in the cyanosis. The vicious cycle of the hyperspells, the pathophysiology is that there is decrease in the arterial saturation of the oxygen, there is stimulation of the respiratory center, there is hyperventilation, which leads to increased systemic venous return. In case of the fixed right ventricular outflow tract obstruction, the increased venous return increases the right to left shunt, and hence there is worsening of cyanosis. Then the treatment of the cyanotic spells and or TED spells um, is as follows. The important thing which is to be done for the treatment is to break the cycle of the vicious cycle that we have discussed. So first of all, what is done? The knee chest position is done. High flow of oxygen is given. Morphine sulfate is given. Morphine sulfate will do two things. It will stop the hyperapnea and it will suppress the respiratory center. Sodium bicarbonate is given. Sodium bicarbonate will reduce the respiratory center's stimulating effect on the acidosis. Beta blockers will slow down the heart rate and they will also help in the reversal of these spells. If the above measures are not successful, then we have two options. One is ketamine, which will increase the systemic vascular resistance and it will also sedate the infant. And the vasoconstrictors are given. The doses, you don't need to memorize them uh, because it is beyond the scope of this exam. So, signs and symptoms of TOF are there is cyanosis, oxygen saturation, it is less than 70%. There is delayed puberty, normal pulse is there. Left anterior hemithorax bulge can be seen because of long-standing right ventricular hypertrophy. Systolic murmur can be heard, which is very loud and harsh, and it is the ejection type of the systolic murmur at the upper left sternal border. Uh, Pulmonary stenosis, it is directly proportional to the harshness and the loudness of the murmur, the degree of pulmonary stenosis, and the murmur reduces during the hypercyanotic spells. S2 is single, and there is soft P2 component, and continuous murmur can be seen in case of the prominent collaterals. Diagnosis can be made antenatally and postnatally. So, chest X-ray, the characteristic shape of the heart is there, which is known as the boot-shaped heart. So, this is very, very high yield. And on ECG, it can be normal at birth. Sometimes you can see the right axis deviation or right ventricular hypertrophy. Echocardiography is diagnostic and confirmatory in case of TOF, and it will show the extent of aortic overriding of the septum. It will show the location and the degree of the right ventricular outflow tract obstruction, the side of the aorta, the size of the pulmonary valve, the main and proximal branches of the pulmonary arteries, PDA if present or not, and the pulmonary atresia. The cardiac catheterization, it is not usually done now, but for the purpose of the explanation and the examination, just keep in mind that it shows the systolic pressure in the right ventricle equals the systemic pressure. So, pulmonary artery pressure lower than normal by 5 to 10 millimeters of mercury, and the oxygen saturation, it is directly proportional to the magnitude of right to left shunt. Then the complications of the TOF. The complications of the TOF, they include cerebral thrombosis, brain abscess, and infective endocarditis. Cerebral thrombosis occurs in the cerebral veins and dural venous sinuses because of extreme polycythemia and dehydration. It is most common in less than 2 years of age and usually have iron deficiency anemia. It is treated with adequate hydration, phlebotomy, and volume replacement with albumin in polycythemia. Brain abscess occurs in those who are more than 2 years. There is insidious onset. It is manifested as low-grade fever, behavioral changes, headache, nausea, vomiting, seizure, signs and symptoms of the raised intracranial pressure, focal neurological signs. Diagnosis is done with contrast-enhanced MRI and CT, and the treatment is done with the antibiotics and the surgical drainage. The treatment of TOF includes the treatment and the prevention of TET spells. In order to prevent the TET spells, the beta blockers are given, the doses are not important, and correction of iron deficiency anemia is indicated because we said that polycythemia is protective and the target HB is to be kept above 10. The iron deficient patients, they are more prone to the cerebrovascular accidents. The surgical treatment involves the palliative shunt, which will increase the pulmonary blood flow, which is done at around 6 months. Then the indications of surgical treatment are the neonates with TOF and pulmonary atresia, infants with the hypoplastic pulmonary annulus and pulmonary arteries, and unfavorable coronary artery anatomy, and those who are less than 3 to 4 months of age who have been medically unmanaged. And if the weight is less than 2.5 kilos. So the procedures which are done is the modified BT shunt, Waterston shunt, and POTS procedure and complete repair. So this is all about TOF. The important thing is that you should know the components of TOF, the pathophysiology, why is the cyanosis happening, and how the cyanosis can be alleviated, the management of the TOF, and the characteristic ECG features, the characteristic chest X-ray features, and the treatment. So this marks the end of the cyanotic heart conditions, tricuspid atresia. It is not frequently asked in the exam, so I will skip it for now because of the shortage of the time. I will just briefly discuss in 1 or 2 minutes transposition of great arteries. So transposition of the great arteries, it is a condition the left in which the aorta arises from the right ventricle and the pulmonary trunk arises from the uh, left ventricle. So there is a switch of the great arteries. They don't arise from their normal anatomical positions. Instead, there is a switch, and sometimes it is associated with the uh, uh, any septal defect, and sometimes the septums are intact. So in cases in which the septums are intact, there are two parallel circulations. So this is incompatible with life. So again, a communication has to be made in order to uh, prevent death. So the important thing to remember in case of the transposition of the great arteries is egg on side appearance on chest x-ray. So egg on side appearance on chest x-ray shows that the condition is transposition of great arteries, and transposition of great arteries does not present with any murmur. Instead, there is severe central cyanosis. There is no murmur, there is severe central cyanosis, and on the ECG, chest X-ray, you can see the egg on side appearance. In total anomalous pulmonary venous return, there is no direct communication between the pulmonary veins and the left atrium, and they can either drain into the right atrium or the systemic venous tributaries. It is of four types: the supracardiac, cardiac, infracardiac, and the mixed type. And the characteristic thing which it needs to be remembered is the chest x-ray finding. On the chest x-ray, you can find a snowman sign, or also known as the figure of the eight. So this is all about the acyanotic and cyanotic heart conditions. I have tried to discuss all the important high yield topics, but uh, since there was shortage of time, so I could not discuss some of the diseases in more detail. So does any one of you have any questions? Please feel free to ask.
Good evening, ma'am. Can you briefly
Yes.
explain what are the indications for digoxin in uh, ventricular septal defects? Thank you.
Okay. Okay. So in ventricular septal defect, we know that there can be features of the congestive heart failure. So in order to treat the symptoms of the congestive heart failure, and in order to improve the overall function of the heart, the digoxin is given when other drugs are not working. I hope this is clear now.
Yes, ma'am. Thank you.
Okay. Any other questions?
Hello, ma'am.
Yes.
Could we get it in PDF as you told us we can have your lecture in PDF after your.
Uh, I think you can have access to this PDF. I will confirm with the management team if anyone who is with us can let the participants know.
Yeah, kindly please, because I joined late. That's why I want to go through thoroughly through this lecture.
Okay. Um, are you taking the FOP regular sessions? Because I have also delivered a cardiology, very detailed 3 hour lecture of cardiology. If you are taking that course, you might have access to that PDF as well.
I'm not taking, I want to take that
Okay.
course. That's why I attend your
Okay.
lecture.
Okay. I'll ask my management team.
Okay, thank you.
Yes, I think they will be sharing it with you. And if you have any problem having access of this PDF, you can contact the number which is mentioned on the screen
Okay, ma'am,
and they
thank
will
you.
guide you further. Okay. So MRCPCH FOP and the TAS exams, they're very basic and it's just that you need to know the pathophysiology and some high yield points about each of the cyanotic and acyanotic heart condition. You don't have to go into very detail, okay, of each of the topic. Any other questions? Okay, so I'm assuming that everything is clear and there are no questions anymore. So thank you so much. But before I wind up, just a quick recap of what I discussed in the beginning of the webinar, that the Med Exam Expert team, it is launching an important exam questions workshop, which will be started from 20th of January 2026. It is a 1 month course. The components of this workshop is that you can have access to the 4 live sessions, the topic wise sessions, the live session recordings, recordings of the previous workshops. There will be PDFs available to you, and you can have access to the solved recalls of the last 5 years, which is very, very important. You can have access to the mock exams, at least 6 papers. Topic wise test can be there, and you will also have access to uh, vast question bank, which will comprise of 3,000 questions, which are FOP oriented, and 2,000 questions which are TAS oriented. You can also have access to the PDFs of the book, all the important files and the notes, and you can also be a part of study group discussions either on the Telegram or on the WhatsApp. And for the month of the December, Med Exam Expert team is offering 50% discount on all the courses. For further information, please contact the number which is mentioned on your screens. This marks the end of our today's webinar. I thank you all for your participation and I wish you all the best for your MRCPCH exam journey. And if you have any questions, please feel free to ask any one of us from the management team. We will be more than happy to facilitate you and to help you through your MRCPCH journey. All the very best and thank you so much.
Thank you, ma'am. Thank